Vimi, you just moderate, Vimi.
Yes, sir. Yes, sir. Yes, sir. Yes. No problem.
Yeah, Ritika.
We are good to start, sir.
Morning. Yeah. Okay. Yeah. I'll come to Secunderabad. From there, we'll go. Right. Yeah. Thanks.
Dr. Vimi, we are good to start.
Good evening, everyone. Welcome to the weekly webinar session about heart and lung transplant related topics. Today we have an interesting topic about changing heart and changing lives. As we know, the cardiac transplant has been there for a long time, but many of them are not aware about when to consider a cardiac transplant, or what are the indications, and what are the usual problems that that occurs during cardiac transplant, and how to follow. So to talk about this, we have our speaker, who is our cardio transplant surgeon from Yashoda Hospital, Secunderabad. He's Dr. Giridhar Prasad. So sir is leading the cardiac transplant service in Yashoda Hospital. So sir was trained in New Zealand, and he's got an enormous exposure in cardiac transplant, and he'll be giving his thoughts about the cardiac transplant, especially the changing heart, changing life. So this is a new concept, especially to the pulmonologists and all other physicians who are not aware about many new ideas about the cardiac transplant. So we look forward to the session. Over to you, sir.
Thank you, Vimi. Good evening, everyone, and thank you for joining us on this webinar. I'll just share my screen. Is it visible to everyone?
Yes, sir. Now it's visible.
Is it visible? Okay, fine. Thank you. So I'm Dr. Giridhar. I'm the heart transplant surgeon for the Yashoda group of hospitals, and I'll be taking care of heart transplants. Hello? Can you hear me?
Yes, sir.
Yes, sir. We can hear, sir. Yes, sir. This window.
So shall I go ahead?
So your slides we cannot see, sir.
I don't know. It's working over here. It's
Sir, we can able to see, sir.
I can see the slides.
Yeah, sir, I can able to see.
Yes, sir. Yes, sir. Now fine, sir.
Now it's okay. Okay. I think there's some. So yeah, I'm Dr. Giridhar. I'm the heart transplant surgeon for the Yashoda group of hospitals, and it's been about 5 months since I joined, and it's great to be on this webinar. A little bit about myself. So I'm basically passed out from Government Medical College in Mysore, followed it up with DNB General Surgery in St. Martha's Hospital in Bangalore. Then I went on to do my MCH from Jayadeva Institute at Bangalore, where we used to perform about 3,000 heart surgeries a year. It's one of the biggest centers in the country. And after that, I moved my way to being an assistant professor in the same institute. And then I went on to be a junior consultant in Care Hospital, Banjara Hills in Hyderabad. I went to do my fellowship in adult cardiac surgery and heart and lung transplant at Auckland in New Zealand. And following that, I've gone around Kurnool, and then I was heading the department at Care Hospital in Vizag. And finally, with the aim of going ahead with the heart transplant program, as soon as I was offered a job at Yashoda, I kind of grabbed at it. And here I am. So I'll just get into the topic. This is Auckland City Hospital, where I trained, and beautiful place, lovely country, and the unit was extremely well-oiled unit, functioning with a great amount of precision, especially when it came to the heart and lung transplant program, the coordination, the logistics. As you can see, we had our own private jet on the left bottom corner. And we also had the air support from the airport in Auckland to the rooftop of our own hospital, just to save about 20 or 30 minutes of traffic time. So that's how much they took care of the transplant program, spending a lot of money. It's a government funded program. So, and we were the only transplant unit in the entire country. So Today's topic is changing hearts and changing lives. I will briefly go into a little bit of the history of cardiac transplant. I was told by Vimi that this is predominantly a pulmonology group on this webinar. So I'll just delve into a little bit of history and then take you into the indications for cardiac transplants. So there's this wonderful saying, history about history. Those who do not remember the past are condemned to repeat it. So we have to learn from our mistakes. We have to learn from what goes wrong and hope that we do better in the future. So heart transplantation was first performed in the course of a lot of experiments since the beginning of 20th century. And it'll be really surprising to know that the first heart transplant was performed by Alexis Carrel and Charles Guthrie in the University of Chicago as early as 1905. So in this, what they did, the heart of a small dog was removed and transplanted into the neck of a larger one. This is a schematic diagram of the same procedure. As you can say, they use the carotid artery and the jugular veins to give connections to the heart. Following this, there was this maverick surgeon called Demikov from Russia. And he did extensive amount of work, and he had reports of heterotopic heart transplantation being done in the inguinal region. Of course, these were all animal experiments. Then there was a heart being transplanted into the lung thoracic cavity. And he described about 24 variants, and he mentions 32 days survival of the graft. He was such a maverick. He also did this head transplantation in dogs, as you can see in the picture. So quite the outstanding surgeon with technical prowess. Didn't really get his due. By 1950, there was evidence of the feasibility of heart transplantation and recovery of adequate function of the grafted heart. But there were a few major concerns. What were they? One was the maintenance of the recipient animal. That is, keeping the recipient alive pre-op, intra-op, and post-op, including the immunosuppression and dealing with the new hemodynamics following the transplant. Then there was a preservation of the donor heart, the graft, what we call. So preserving it through from the time when we explant it from the donor, bringing it onto the recipient's theater and implanting it. And then the surgical technique to minimize ischemia. Which involves, so the main focus was always to reduce the amount of ischemia time for the heart. So how did they go about this? So in 1957, a couple of surgeon scientists called Webb and Howard, they discovered that you can preserve the heart in dogs by flushing the organ with cold potassium citrate. So this was basically the start of the cardioplegia. So these authors actually opened up the pathway for long distance procurement, and these are the large shoulders that we are standing upon. Then they went on to the technique to minimize ischemia. In this, in 1950, there was this group, Dr. Shumway's group at Stanford. So Dr. Shumway is one of the greatest names in heart transplantation. Of course, he was not very well known. We all have heard of Christian Barnard because he obviously did the first heart transplant. But the research, in fact, Christian Barnard worked with Dr. Shumway and Dr. Richard Lower at Stanford. And they were the ones who pioneered all the techniques, the surgical techniques for heart transplantation. And these people, they found that you can preserve the donor heart by immersing for 5 minutes in a 4 degrees centigrade saline. So as you can see in the diagram, on the left is Dr. Shumway, on the right is Dr. Shumway along with Dr. Richard Lower, who is standing. And these are the pioneers in the Stanford University College who took us technologically, surgical techniques wise. They went really far ahead to give us the basics of doing a transplant for heart. In the mid-1960s, so solutions for key problems were addressed, and they were left with only the ethical and the legal aspects. And finally, on January 23rd, 1964, Dr. Hardy performed the first human heart transplantation. Actually, it was a xenotransplant. So what he did was he took out the heart of a donor chimpanzee and implanted it into a human being. And the patient died at about 1 hour later. Obviously, the concerns would have been with graft rejection because in those days, the immunosuppression was not really advanced. That's Dr. James Hardy. He is also the first person to do a lung transplant. and he's
Hello.
Sir,
I think Giridhar sir.
I'm calling him, sir.
Yeah.
Hi. Sorry about that. I think we just lost a bit of connection.
It restarts.
So, can you see my screen?
No, sir. Screen, no, sir.
Yeah, I'll just put it up again. Sorry about that. So, we have two concepts. One is DCD donors and one is DVD. DVD is the regular one, which we hear of on an everyday basis. It is donation after brain death. And the first one, coincidentally, was donation after circulatory death. So they waited for the heart to stop, and then cardiopulmonary bypass was initiated in the donor, and they had to remove the heart and then implant it. After an initial excellent recovery, the patient died on the 18th postoperative day. So this was by and large a very successful transplant for those days. So that's Dr. Christian Bernard on the left, and that's the patient, the recipient, along with the nurse on the right. So that's the donor, and science owes her a lot. So what's the story in India? So in India on 17th of February 1968, hardly 3 months into the first transplant in the world, there was this excellent, very good Bombay surgeon called Dr. Prafulla Kumar Sen, PK Sen, who's known commonly in our field, who transplanted a human heart, becoming the 4th surgeon in the world to attempt the feat. And even though the patient survived just 3 hours, the feat won a lot of worldwide acclaim for Dr. Sen, because no one really thought that in India, which was in scientific terms, we were quite backward then, that we would actually be able to do a heart transplant. But Dr. PK Sen is a pioneer, and the Indian heart transplant program owes him a lot. World over, then came the disenchantment period, where only 4 centers were running throughout the world, one in South Africa and a few in America and one in Paris. And why was this? This was basically because they had a lot of failures following the transplants, because there wasn't enough immunosuppression and it was at its infancy. So what was the game changer? So cyclosporin was the game changer. And in 1978, cyclosporin was introduced in the kidney transplant. And finally, in 1980, they used cyclosporin even in heart transplant at Stanford. And also, they developed something called the endomyocardial biopsy. So this is a biopsy done by the cardiologist by putting in a small little catheter through the femoral or the radial artery, and it'll have a small little biotome in it. And they take out a small piece of the endomyocardium. So this is used in the post-op period, and once you put it on the microscope and you look for any signs of rejection, early rejection, and based on that, based on the amount of rejection, you can titrate up your immunosuppressants. So these two things, one is cyclosporin, that is the immunosuppressant, and the way of detecting rejection, that caused a lot of change in the scenario for heart transplants. So finally, coming to the burden of heart failure in India, the heart failure in India is quite high. As you know, cardiovascular disease per se forms about 1/3 of all the possible possible deaths in India, and heart failure has the prevalence is ranging somewhere around 1.3 to 4.6 million. So that's a huge number. That is 46 lakhs of people in India are on an everyday basis. They are suffering from heart failure. They may be in various stages of heart failure, and at least about 20% of them require heart transplants. Now, India has maintained a registry about from 1994 when they did the next heart transplant at AIIMS by Dr. Venugopal. And since then, we've done about 113 heart transplants. The data is up to 2021. So if you probably extrapolate it to 2023, we've done more than 1,200 heart transplants all over the country, more than 120 heart and lung, and more than 400 lung transplants. So what did we do at Yashoda? So at Yashoda hospitals between 2014 and 2023 is when our heart and lung transplant situation team and department has been running. We've done about 18 heart transplants, and we've been very aggressive, and we've been very generous, so to say, in terms of organ donations. We have the largest organ donation program running in the country, and of which almost 368 organs were donated, of which about 10 hearts and 36 lungs were also donated to the pool when we didn't have adequate recipients. So we've been quite big on the organ donation program in the state of Andhra previously and Telangana right. So getting into the basics of the process of evaluating a potential candidate for heart transplant. So what do? One is we determine whether an indication is there for listing the patient onto a cardiac transplant program or even sending a referral to the heart transplant surgeon. And sometimes we do have patients who may have heart as well as some liver problems or heart and lung or heart and kidney problems. And then we need to look at whether they are candidates for combined organ transplantation. Initially, the combined organ transplantation, multi-organ transplantation was less than 1%. And nowadays it is almost 7% of all the transplants. And then what happens to this patient once the referral comes and the patient comes to the cardiac transplant center is that we review all the potential indications. We determine whether there is any way that they don't need the transplant, because as a surgeon, what is most important is not what you should do, but what you should not do. So we look at any relative or absolute contraindications to heart transplant and then take it forward. I'll just go through the guidelines for cardiac transplantation. These guidelines are more or less the same with very, very small, insignificant variations. And these are between ISHLT, which is the International Society for Heart and Lung Transplant, the ESC, and the ACCHA. These are the guidelines that I have used to enumerate all the indications. So number one, the indication is cardiogenic shock. So shock requiring what? You can't just have a patient in cardiogenic shock. Obviously, he'll be having intravenous inotropic support. And also sometimes he or she may have circulatory support with an IABP device. And nowadays we have something called ventricular assist device. So we have the LVAD or the RVAD, or we have a BiVAD. And these are usually done to maintain organ perfusion. The ventricular assist device may be a bridge to transplant, a bridge to recovery. And the patient is usually in a condition where he needs to get off all these supports and get a new heart. Number two, persistent NYHA. 4, heart failure, symptoms which are refractory to any kind of optimal medical or surgical therapy. So what do you mean by medical therapy? So they go through the whole range of heart failure drugs. It could be ARNIs and diuretics, beta blockers, ACE inhibitors, and ARBs. So all these have been tried. They are at maximal dosage and still they have persistent heart failure, which is class 4, which means they have it at rest, where they have symptoms of SOB, shortness of breath, or they might have some palpitations, chest pain, any of these symptoms, predominantly SOB, at rest. And surgical therapy. So some of these patients are ischemic cardiomyopathy. They might have triple vessel disease. They might have diffusely diseased vessels. Whether we've tried all the possible ways of revascularizing, or we've deemed them as not amenable to any kind of revascularization procedure, maybe because the heart has gone beyond the needs of revascularization, which means that they have large scarred tissue. The heart is not going to improve even if we stent the patient off or if we put any grafts for the patient. So the heart is already scarred, there's ejection ejection fraction is low, less than 30%, and it's not going to improve with any of our procedures. So we need to ensure that all these are done and dusted, and we do not have any other way out but a heart transplant. So it's like the last thing that we want to do in the patient. Third indication is intractable or severe anginal symptoms in patients with coronary artery disease. Again, they are not amenable to any kind of percutaneous or surgical revascularization. And so these are also patients you will have. Sometimes you hear of patients, they've undergone a stent. Recently, I had a patient, so he undergone a stent in April. Then that got blocked off. And then I was given a referral by the cardiologist for revascularization surgically. We did a triple bypass. And within another 3 months, again, the patient, in spite of maximal medical therapy to control, clopidogrel, icosapent, high doses of statins, again, the grafts are blocked. So now we are again, the cardiologist is putting in a stent, but we are thinking that eventually this person will have intractable coronary artery disease, and it will eventually lead to a situation where he has low EF. We can't do anything more about the disease, and he might be on the transplant list. So those kind of patients are also an indication. 4, intractable life-threatening arrhythmias. So we would have heard of all these patients where they'll have SVTs or some sort of arrhythmogenic foci within the heart. The cardiologist sometimes puts ICD, or they might be also on some sort of catheter ablation for AFs and SVTs. All these things are not helping alleviate the patient's symptoms, and every time he is having continuous arrhythmias which are reverting a little bit with the device, but sometimes they are not reverting. So these patients need relief, and heart transplant will be the final way for them. Selected patients with restrictive and hypertrophic cardiomyopathies. This is a very small subset. Patients with refractory severe heart failure and non-obstructive hypertrophic cardiomyopathy. These indications, since they are lower in the list, these are not patients which are commonly seen. And in congenital heart disease, where the patient has had a congenital heart disease and still persistent, that is, they've undergone a palliative or a corrective surgery, and they are having NYHA class 4 symptoms. So some of these are post-Fontan patients for single ventricle disease, and they have persistent protein losing enteropathy. So relative indications is recurrent unstable ischemia, recurrent instability of fluid balance, renal function not due to patient non-compliance. So they have a renal function which is going down, and that is probably due to a low cardiac output, and these patients need to receive a cardiac transplant. Coming to the situation where we need to know when not to do a heart transplant, that's most important rather than just knowing when to do it. So one is patients having systemic illness with a life expectancy less than 2 years. So when can this be? These can be some kinds of sarcoids or systemic connective tissue disorders, or there can be malignancies where that the patient doesn't have a very long-term survival. Then there's no point putting the patient through a heart transplant and causing more amount of pain, just to be more generous. Well, the other one is irreversible pulmonary hypertension is considered an absolute contraindication. So what is irreversible PH? So a PVR, pulmonary vascular resistance of more than 3 Wood units, which is irreversible. So how the cath lab, in the cath lab, the cardiologists, what they do is a cath study. So once they put in their wires and they are measuring the pressures within the heart, I won't go into the details. Once they feel that the pulmonary vascular resistance is more than 3 Wood units, so they give some drugs like sodium nitroprusside, nitroglycerin, or milrinone, and they look at the effect of the drugs on PVR. So if it reduces, then it's a reversible. So that means it's not yet gone beyond the condition where it's it's going to be a problem for us post-transplant, heart transplant. So then we can go ahead. But if it's irreversible, then that's a serious contraindication to isolated heart transplantation. And usually these patients are candidates for heart and lung transplant. So you need to take out the diseased lung, because already the lung is having a lot of pulmonary vascular disease, whereby the pulmonary vascular resistance is quite high. So the other contraindications are clinically severe symptomatic cerebrovascular disease, or the patients are on active drug abuse. They can't get off their smoking or alcohol or any kind of drugs. And of course, if they also have a history of multiple demonstrations of non-compliance with drug therapy. The other thing is multisystemic disease, like I've already alluded to, some cases of amyloid and sarcoid, where they would not be good candidates for heart transplant. Relative contraindications. So nowadays, initially people used to have a contraindication for above 55 or 60. In fact, in most of the other countries, apart from the ones like the USA and in a few European countries, most of us still follow the 55 to 60 rule. So no transplants above that, but they have seen that you can still transplant above 70 years, but yes, the results are still very much in their infancy, and it has been seen that the survival rates post-transplant for more than 70 years is not very good. You can transplant, but the results are not so great. Obesity is another factor, which is an absolute no-no, sometimes a relative no-no for heart transplant. BMI more than 35, we request them to come back when they've got it sorted out. Diabetes mellitus with poor glycemic control, again, not because it's not controlled, but obviously there'll be more end-organ damage. And that is something which will look at probably a multi-organ transplant and not just a heart. Irreversible renal function, again, is a relative contraindication. We are looking at multi-organ transplants like heart and kidney. So the other relative contraindications, cancer. So cancer can be again, you look at the survival chances. You need to talk to an oncologist, figure out if they've undergone treatment, what is their survival rates, what are their recurrent rates, which is why it is a relative contraindication. Acute pulmonary embolism, within 6 to 8 weeks, we cannot go ahead immediately. We need to wait for that to resolve, because again, that will cause a lot of, we can transplant the heart, but you have remnants of the acute pulmonary embolism, or it goes into a CTEF sort of situation. We end up with a lot of problem with the RV failing in the new heart. Tobacco use within 6 months or any kind of substance abuse, again, I've told you, it's more of a absolute contraindication. The other more important, though I'm talking about it quite in the last, what we've seen, especially in my training in New Zealand, is that we used to look at the social support and the psychosocial assessment papers, and we need to have the patient with a good social support as well as psychologically quite oriented towards heart transplant. And when the patient is put on the list, there will be at least 4 or 5. He may have just 1 or 2 times of investigations with respect to the whole profile of our heart transplant profile, blood and other investigations. But psychosocial assessment, he goes through almost 4 to 5 times, and until the surgeon is quite sure that he is motivated towards a heart transplant. Because heart transplant is not just like any CABG where you do a graft and then the patient can take a few drugs and maybe he might skip it a little bit. It may not affect their lifestyle a lot, but here we are looking at patient motivated enough to stick to the drug therapy post surgery, because that is the make or break deal. And if they skip their immunosuppressants, there's nothing that we can do for them, and it's basically a wasteful procedure for someone who's not motivated enough to get a transplant done. Again, peripheral vascular disease, that would limit their rehabilitation. So it's quite a big thing. Post-heart transplant, they have to be rehabilitated. And if the peripheral vascular disease does not allow them to do walking or what kind of rehabilitation procedures we ask them to do, then that will also be an impediment to achieving better results in heart transplant post-operatively. So ultimately, the decision to list a patient for transplant is not based on any one test or factor, but there are multiple factors. We need to look at the indications, the contraindications, the blood tests, the psychosocial assessment, And because we need to be sure, heart transplant as of today has survival rates somewhere around a median survival rate of 12.2 years. So the 1 year mortality survival rate is about 90%. 3 years is about 75%, and 5 years is about 65 to 70%. So these are amazing amount of results considered compared to what we used to have in the 80s or 90s. And that's a large, in large, that is due to the advances in technology in terms of supporting the patients preoperatively. We have a heart failure patient who's really crashing. You have newer devices, you have ECMO, you have the LVADs and ventricular assist devices. You have various, or even catheter devices like Impella, which can tide over this huge process where we need to get the patient onto the registry and then get a heart. So all this has caused a lot of support system for the patients of failure, heart failure. And this in turn reflects for us on the results post-heart transplant. So we need to look at a lot of factors so that we don't have suboptimal outcomes post-transplant. I'll just briefly talk about the stages of heart failure. So, So there's stage A, B, C, and D. Now, stage A and B, as you can see, A is when there is high risk for heart failure, but without any structural heart disease or symptoms. Stage B is when there is structural heart disease, but without symptoms or signs of heart failure. These people are just, beginning to be on the pathway towards heart failure. Stage C and D is what we are interested in. Stage C is where they have prior or current symptoms of heart failure. And stage D is where they are in absolute heart failure requiring interventions. They may be admitted or they are on a lot of drugs. So how does this work out? So if you look at physiologically the hemodynamic progression of heart failure, as you can see in the graph, it's quite easy to understand the LV volume on the x-axis and the LV pressure on the y-axis. So stage A and B, there is not much of change. So stage C, what happens is the end diastolic volume starts to increase a lot. So the heart is becoming bigger and bigger. So on an echo, you will have a patient with the LV volumes that we look at end diastolic volume. So that will start to increase. Stroke volume is still less. BP is still good. The patient will have some amount of symptoms. Like I said, stage C. So the patient will have NYHA grade 2 or 3 symptoms. But it's manageable with medications. Now, slowly, the patient starts to go towards stage D, which is he has NYHA 4, that is at rest. Now, why does this happen is the end diastolic volume starts to increase rapidly, but at the same time, the end diastolic pressure. So there's a lot of pressure generated in the heart chambers, which is causing no forward flow. So the stroke volume has decreased. That means the cardiac output has decreased, which immediately shows up as a decrease in BP. So the patient comes to your OP. For 6 months, he is fine with BP of 100. And suddenly you see it not going above 90, sometimes 80. Patient has cold, clammy peripheries, complaints of more severe symptoms, not able to walk. He is breathless, he or she is breathless even at rest. When he comes to your outpatient, you know that they are significantly breathless. So that is when they've already reached that stage where they need to be referred to a cardiac transplant center. So these are just a small table showing all the clinical, biochemical, imaging, and hemodynamic parameters that we look at for advanced heart failure. What I would like to go through is, this is a huge list and it's easily available anywhere, but what I'd like to go through is few very important signs and symptoms, which there is a small little mnemonic developed by the ACCHA. It's called I Need Help. And that should prompt a referral. This, I think, is the crux of my presentation. And I'd like you to take some time to listen to this. Very important. So this is a mnemonic for anybody in the outpatient. It could be a physician, a pulmonologist, cardiologist, anybody to evaluate. This is when you need to refer the patient for a transplant evaluation, because this indicates end-stage heart failure. So what is this? I need help. So inotropes, obviously, we have a patient who's admitted, low EF, less than 25, and he has ongoing or requirement for any of the inotropes, dobutamine, milrinone, dopamine. So I stands for inotropes. NYHA class. So you have a worsening class of NYHA. He's gone from NYHA 3, where he has tolerable symptoms, decreases on rest, and then he moves to 4, where he has symptoms even at rest. And then this can be associated with or without high BNP or NT-proBNP. So that is your N. E for end organ dysfunction, where there is worsening renal or liver dysfunction. So as you can see, all of these are they're a progression. There is no one cutoff value. There is no one. You can't decide about the patient being a candidate for cardiac transplant referral on just one set of investigations. You need to look at his previous one. And if there's a worsening renal or liver dysfunction, then obviously it means that the patient is going into low cardiac output. All drugs are not helping, and he needs to get to a place where he will be given options for it. Could be just cardiac transplant, it could be a LVAD, it could be any of the above, but he needs to get to a cardiac transplant center where he is better dealt with in a heart failure clinic. Ejection fraction, very low ejection fraction, less than 25%. So there is a lot of discussion about this. People say, no, even we can go to 20, some say 30. But yes, there is a number that they've given, and that is 25%, less than 25%. We definitely need to look at referring. Defibrillatory shock. So this is another thing. So some of the patients will have ICDs, and they'll just complain that we are getting shock. Too many shocks nowadays. It was not like this. So obviously their arrhythmia. This is the category of patients which I told in the indications. So they have a lot of arrhythmias which are not being controlled by your ICDs. Hospitalizations. So at least one hospitalization with heart failure in the past 12 months. Edema or escalating diuretic agents. So you will see that persistent fluid overload, pedal edema, body is puffed up, increasing. Diuretics are going from 40 mg, 80 mg, 120 mg. So they definitely need to be referred. Low BP. So like I told you earlier, patient was a very good 100, 110 BP with some amount of symptoms of failure. Now he is at rest symptoms, and BP is persistently below 90. Prognostic medications. So we can't titrate any of the ACE inhibitors. All are at maximal doses. Beta blockers, ARNIs, or MRAs. They are all at maximal doses, and there is no other way to go but surgical. So that is when you need to refer. So I need help. Inotropes, NYHA class increasing, end organ dysfunction, renal or liver parameters increasing, ejection fraction less than 25%, inappropriate recurrent defibrillatory shocks, hospitalization, at least one in the last 12 months, edema or escalating diuretic agents, low BP less than 90, and prognostic medications which are being at the maximal dosage. So these would be your main criteria for referral. So the field of heart transplant, to conclude, the field of heart transplant has seen tremendous growth since 1967, and they are increasing the donor heart utilization and ensuring there is more access for everybody. And at the same time, there is advances in the field of mechanical circulatory support, like I told you, left ventricular assist devices, ECMOs, and also total cardiac replacement. These all provide hope for patients with end-stage failure, and India being such a large populace are being affected by cardiovascular disease, and as we saw, nearly 40 lakh people are suffering with heart failure. So a lot of them will be needing heart transplant. It's just that they're not getting referred. We're probably not picking them up, and also there might be a small amount of financial issues. Of course, the more we do, the financials will have to come down. So if the referral comes at the right time, I think we can save more lives with better survival rates. Thank you.
Thank you, sir, for the excellent presentation, sir, especially about the changing advances, the need for right referral, and the criteria that I need help, which is very consolidated and which everybody can remember about the criteria for referrals. And it was good to hear from you about the history of cardiac transplant, especially because when we were studying in the medical school, we used to hear the name of Shumway and see the videos of the Stanford especially about how they started the cardiac transplant, and finally it's a privilege to work in a center where we are also doing a cardiac transplant and lung transplant and whatever the way that is going on. So I have some few questions, sir, especially
Yes.
from a pulmonology point of view, sir. See, most of the time, what comes to our OPD is a group of heart failure, which is non-pulmonary origin, and usually they'll be on digoxins and diuretics. So, do we have any up to what medical management, sir, we can usually, or up till how many class of drugs till which we can consider the medical management, and after that we say, okay, now I think almost medically I don't think there is beyond this and we have to consider. So I in that I need help, I saw that last one, there is ARBs, diuretics and other drugs. So just wanted to ask about that.
So like I said, there is no for each patient, the kind of the dosage of drugs will vary, obviously. But what we'll be looking at is a whole conglomerate of things. Like you look at the echo, you look at the volumes, have they increased? Has the LVEDP increased? The EF has fallen. The BP has decreased. And this is in spite of you having increased the dosages from the previous instance. So let's say you were on whatever, let's say Lasix 4.
Sir, hello. So you can continue, sir. There was a small.
Like I said, yeah. So it's just that you have to look at all the parameters, like volumes, LVEDP, and you need to look at all these, how they have varied from the last time you saw the patient, and you up titrated some drugs. And is it worsening or is it getting better? So that's the only way you will realize. There is no hard and fast, like, okay, I've gone to 40 mg, now I think we'll refer. No. You go to 80 mg, that's true. But then at the same time, when you put up 80 mg and then you look at the echo after like 1 month or something, and you look at the patient again, symptoms are better, you talk to them, you look at the echo, and only if those are worsening, then you know that your drugs are not helping. So then you need to refer. There are no absolute numbers.
And sir, in the most of the other times, what we see in our, especially in our medical training, is especially in the postpartum cardiomyopathy, sir. So, especially in this postpartum cardiomyopathy, is it the same criteria, sir? Do we consider about the cardiac transplant, especially when they go for a shock, or you feel is there any change in criteria or anything?
So as far as in our clinical practice was concerned, we go through the same kind of issues. They have to go through their whole medical management, optimized medical management, give them time, and then only they can be considered. Yes. There is no shortcut. They have to go through the entire protocol of medical management. They have to get the benefit of medical management. Without that, we are not going to post them on the list.
Okay. And other doubt is that, sir, like lung transplant where they require a lifelong immunosuppression, is it the same with the heart, or is there any change?
Absolutely. There is no change. Probably the dosages would be a little bit lower because of the the volume of the organ being lesser than a lung.
Okay.
And probably titrating it is probably easier with the heart. But there is no change in it. He has to have immunosuppressants lifelong.
And the other thing is that, sir, like we see that when there is a retrieval of organs, we can see that always a cardiac transplant surgeon will be the first to remove the heart, and they will be first to fly from that retrieval center to the recipient center. So how much time do you give, sir, from the time you explant the donor heart
So
to
4 hours. 4 hours is the ischemic time for a heart. We need to implant it within 4 hours. That will give you the best results. I think for lungs, it's a little bit longer. You can afford to go up to 6 hours,
Yes.
but heart has one of the shortest times, and it takes just 4 hours.
I would.
I mean, like, this for ideal results.
Yes.
Not that you can't implant it, but to get the best results, yes, 4 hours is what we recommend.
I think your from your presentation, it was very nice to see the histories, and I mean it's a especially your presentation history. I think it really gives a flashback about all the videos of cardiac transplant which we used to see in the childhood. So it was a very excellent talk, sir.
Thank you.
I'll just see any more questions from the audience, sir. 1 second. I think there are no more questions. So there is no questions in the chat box. So we will, I think time is also 7, almost 45 minutes past 7. So I think there are no more questions. So we will end the session, sir. So thank you for the excellent presentation, sir, in your busy schedule to
Thank you.
talk about the cardiac transplant. And we look forward to the further session about the cardiac transplant, especially regarding the post-transplant care and about the need for biopsies and other thing in the subsequent days, sir. So once again, thank you, sir.
Thank you so much, Dr. Vimi. Thank you.